We shall now have Dr. Tanvi Haldipurkar, consultant cataract and refractive surgery from Lakshmi Eye Institute, Navi Mumbai, and an amazing surgeon, learned from her father or that innate skill, whichever. She has another wonderful video for us to see. On to you, Tanvi.
Good afternoon, everyone. Thank you, AIOC and ARC, for this opportunity once again to share my video. I'm looking forward to the surgical pearls that our seniors will share here. Of late, I've been served with a litany of hard brown cataracts, and so I'm presenting one here, hoping to learn some tips to do them better. This was a case where the cataract was extremely hard, brownish in appearance on slit lamp. There was a lot of liquefied cortex, which I aspirated with a needle and again re-injected viscoelastic and continued with my rexis. Now, while making the rexis, I kept the flap rolled flat, but it was requiring some extra effort, which made me think of some zonular weakness, although there wasn't any phacodonosis preoperatively. With minimal hydrodissection, the nucleus rotated and I started my nucleus management, and that's where my difficulty began. When I tried to bury in the nuclear core, the back kept moving away from the probe. I was using a blunt chopper, which was quite bulky, and while I was trying to chop the nucleus, I noticed that there was zonular weakness on one side. So I stopped there. I refilled the anterior chamber with some viscoelastic, and I tried to get a better grasp. But again, the bag was moving. Nucleus was truly evading the probe. So I had to do something different. So what I did is I went ahead and put a CTR ring. I filled the anterior chamber and did that. I changed my blunt chopper to a sharp one. I also changed the settings of my phaco machine. I increased the power. I shifted to a burst mode with a higher vacuum, and I tried to it helped to increase the grasp. Now this was a very thick, hard, sticky nucleus, which made it difficult to separate the pieces. But before I could emulsify the fragments, I was making sure it was separated from the bottom plate. Otherwise, I would be pulling the entire nucleus back complex towards the probe. So slowly and steadily, I separated the fragments formed as attachments. I was trying to keep the phaco probe steady and not move too much so I wouldn't hydrate my main wound or cause too much corneal damage. My second instrument was mainly doing the heavy lifting. I filled some viscoelastic whenever it was required. I tried to clear the central part so I could make some space for working. The last piece, however, was emulsified very carefully because I knew that the bag was loose at the place where there was zonular weakness. Here, my foot on the foot pedal had to be pressed very, very carefully to build a slow vacuum and then release it whenever I was too close to emulsifying the entire piece. Also important to note here is that I'm not really moving the phaco probe away from its place. It's right in the center. It is the second instrument, which is the chopper, that is getting my phaco piece close to my probe. It is helping it, nudging it sort of towards it. Now, this is important because there is a loose bag which can get caught with the probe if it does not have any piece occluding it, and it can cause more zonular dehiscence. And once my nucleus was totally out, I made sure that there was no loose cortex or anything lying there. I filled some viscoelastic and took a Y hook just to see if there were any loose zonules or if there was a bigger subluxation than what I had noticed. And as the bag looked pretty stable, I went ahead with the originally planned intraocular lens. Implanting the lens was in no way easy. As you will see now, this was planned for a hydrophilic lens. When I was trying to dial the lens in, the bag would just move with the dialer, and I was worried I was causing more damage to the zonules. So I was trying to use the spatula there to stabilize the capsular edge, and finally, with a gentle motion, I dialed the lens in the back and started rebreathing again, which I had stopped momentarily. I was lucky to get away with it, but there are many things I learned from this case. I should have made a larger rexis to begin with, and when I couldn't do it before, I should have enlarged it later. This would have definitely helped me with my nucleus management and, of course, my lens implantation. And if for a cataract this hard, these are some of my surgical steps which I go to. It is important to make an adequately sized tunnel. We have to remember that we'll be spending more time than an average case to break down the nucleus. So it should be adequate that we don't cause too much hydration and then land up into reduced visibility. A slightly larger rexis, it helps in the nuclear management like it would have for me. It is also important to use the viscoelastics intermittently if the surgery is taking long, obviously to protect the endothelium. And the key to prevent postoperative corneal edema is to keep the phacoprobe steady and in the center. We need to use the other instrument to get the fragment to the probe and probably stay in the iris plane. All of these steps are very easy and everybody does it. So, but I think it's important to highlight them here because it's not just important to finish the
Can
session.
your volume become high?
Your volume has gone down.
Yeah.
Sorry, can you hear me now?
Yeah.
Yeah, it is important to also have a clear cornea post-operatively, not just finish the case and have a lens in the back. So the next point is to use intraoperative devices when indicated. Fortunately, I didn't need anything else, but we can also use capsular hooks in case there is a major zonular dialysis. And the most important thing in the end is to just breathe and keep calm because as the senior surgeons that I see here, it only gets better with time and experience. Thank you for your patient listening.
Yes, that was a wonderful video, Tanvi, and showed a lot of surgical skill being displayed. Dr. Swapna, I would, of course, my question was why did she stay stuck with the small rexes and challenge herself? But she anyway herself discussed that. What I would want to ask you, Dr. Swapna, is would you have thought of using capsular hooks and try to do this surgery when the dialysis was noticed after enlarging the rexes a little bit? Or would you have gone and placed a CTR as and when she did and with the entire nucleus in the bag and then gone ahead and continued?
Yeah, I think she was right in putting in the CTR because I don't think there was much of cortex in that region to obstruct the passage of CTR or later, whenever you need a cortex aspiration to manage that. But of course, anterior support would have been provided had capsular hooks been placed. But one point I needed to highlight here was that I think there should have been more pieces chopped, maybe 8, 10, 12, whatever you want, because and when you aspirate or emulsify 1 or 2 pieces, that gives you a lot of space in the back to manipulate the rest of them, and there's the tension on the zonules is decreased a lot. So a sharp chopper, like you realized later and used, and lots of wedges to make for a hard cataract, right all the way to the bottom, like you did. So that
one more point that the initial hold was hello.
Sorry, I was just trying to ask, because there was that zonular dehiscence and I was trying not to manipulate it more, would you still want to spend that much time trying to separate? Because the separation causes more,
No. It depends on how you're separating.
Okay.
Because when you're trying to exert horizontal pressure, but not in a direction that pulls your zonular dialysis towards you.
Okay.
So that the kind of force, the torque applied is different when you are.
So you're going to use a hybrid kind of a chopping technique, right?
Yeah. So it has to go into the cleft and separate. So
it's going to be a vertical and a lateral separation kind of a thing.
So that decreases it, and it helps a lot in zonular dialysis.
One more point I want
for the benefit of all the viewers and the beginners, I would like the panelists to actually put up their parameters, each of the panelists, that okay, fine, in this kind of a case, what would be their parameters with a gravity based device? Tanvi, you were using a Ertley, right?
Ertley,
Yeah.
yes.
So gravity based device.
There, I think one point I think Dr. Abhijit is trying to say is that at one point I thought I heard you say you increase the vacuum. Yes. Whereas I would have increased the power.
So power.
That was.
It was 80, so I probably didn't want to go more. So what would be your settings? I would also be very interested to learn.
I wouldn't put a high vacuum there. I mean, usually I go for something like 500 or on the Centurion. So I would come down to, let's say, around 300 or so. And the power, yes, the power would be what I'd be, concentrating on more, because I want a good hold.
If you were not on Centurion, I want you to be on a gravity based situation, because that's what all the beginners are going to be on. So what would be your settings in such a case?
I wouldn't have a very high bottle height because of that dialysis you have there. I want to keep the chamber stable. So let's bring the bottle height down to around, let's say 60, 70 from the usual 80 or 90, whatever you're keeping. Put in max power that you can without, creating a problem with the cornea. And vacuum should be very moderate, not too high. Because I usually don't change my settings during the process, like, something for holding and then again for emulsification, another one for the epineural. But considering that, I think the basic thing is having a good power so that you're not pulling on anything while you're trying to, chop.
Do you need more holding power than anything?
Yes, Dr. Ramurthy. Yes.
A couple of comments. I mean, a very nice surgery. Tanvi, obviously, genes can't go wrong. Apart from what all was already said, my additional comment would be that, usually I think you never got a proper chop. The nucleus fragments were sort of attached. And Swapna did make a point, you'd sub-chop them into multiple segments. More important that the chop should extend all the way down to the posterior plate. In these kind of cases, what I do is to create a small subincisional trench, and that gives me a better access to the meat of the nucleus and expose the tip a little more, withdraw my the sleeve a little more, get a deep purchase into the meat of the nucleus, and then go ahead and create a crack. And in case it is not happening right through and through, go into a deeper plane and create, because I found that you are not getting a hold on the nucleus at all. When you are trying to crack, the nucleus is all the time tending to rotate. And sometimes in very hard nucleus, I'm not able to get a crack. All I do is to create the trench into a stop and chop technique. Go right way, all the way to the other axis, create a central thing, make it as deep as possible, put in two instruments, crack them into two heavy nucleus, and then go ahead and so cracking into distinct fragments without the nucleus being attached is most important. I personally feel that, sorry to say that, this whatever dialysis you had, which you managed well, was iatrogenically created, because you are trying to maneuver nucleus pieces without really separating them into distinct segments. And apart from the factors you said, when you use the second instrument, apart from feeding it in these kind of hard nucleus, they also help you to protect them from hitting the back of the cornea, along with the viscoelastic which you stressed upon. Once there's less of the nucleus fragments coming in contact with the endothelium, and use the second instrument judiciously to protect that, then again that goes well as far as the health of the endothelium is concerned.
Now, in this particular case where the rexus was small and the IOL was placed, and when there is zonular weakness, of course, the CTR will take care. There could be these dense hard cataracts. There could be an element of capsulophimosis which could occur in a smaller rexus. Would any of you, instead of enlarging the rexus, think of making, after the IOL is placed, making small nicks on the capsular margin to enlarge it? Would you have thought of doing that? Or post-operatively, the rexus is small, would you wait for phimosis to occur, or would you try to make nicks with the YAG laser?
I would actually refashion the rexus then.
Yeah. After the IOL was put, we could have extended it.
So refashion the rexus.
Yeah.
Right.
Ma'am, one thing, surgeon, but one thing I do phaco also, and one thing I've realized, if you are doing wound-assisted delivery in such a small rexus, if you take the IOL inside and deliver it within the bag itself, there is less of you can say friction or damage to the already that zonular dialysis, because only you have to put the optic into the bag rather than the optic also to be adjusted into the bag itself.
Yeah.
So based on my question, I had actually put up the question for the panelist for the reason that probably we should, in these cases, decrease the aspiration flow rate, because that causes chattering and more turbulence in the chamber, and that is what causes the endothelial damage in hard cataracts. So increasing the power is good, but against that, the aspiration flow rate should go down. The vacuum probably can be medium, as Swapna had said, and that works out very well.
Even regarding the power, just increasing the power could cause corneal wound burns and corneal endothelial damage. So in such cases, at least something like a white star technology will
definitely
help
so
when you
most
have
of the machines are
multiverse
white star.
Basically, ma'am, the machines we use these days, none of them really cause damage because of power. Like Dr. Abhijit says, majority of the damage is actually caused by chattering. So if you can reduce the amount of chattering, that takes care of the endothelium and goes a long way in doing that.
Thank you very much.